So hello everyone. Our today's topic is about the dental caries. So first of all, you should know what do you mean by dental caries. Dental caries we all know it's all known as a tooth decay. So dental caries is also known as tooth decay. It means rotten or the tooth decay. So the term caries it comes from the Latin word that mean as a rot. So this condition is complex and a dynamic process, and it is influenced by multiple factors that initiate and promote the progression of the disease. What is the definition of the dental caries? Remember that dental caries is a irreversible microbial disease of calcified tissue of the tooth that is characterized by the demineralization of the inorganic part and destruction of the organic part of the tooth that leads to cavitation. That is the standard definition of the dental caries. Now here, what do you mean by what is the inorganic and the organic part of the tooth? Well, the inorganic, there is a demineralization of the inorganic portion. What is the inorganic part of the tooth? Well, primarily the inorganic part it consists of minerals that would provide hardness and strength. So the main component is of the inorganic portion is the hydroxyapatite. Remember that is the primary mineral in the tooth that is made up of calcium and phosphate, and it forms the bulk of the enamel and the dentine. This mineral it is essential for the hardness and the durability of the tooth, whereas the organic part it includes most of the proteins and the organic molecules that contributes to the resilience and overall health. That is, we have collagen protein. So this is the primary organic component of the dentine and cementum. We know collagen fibers, they will form a framework that will support the mineral structure. Other non-collagenous proteins that play a role in formation and maintenance of the dental tissues. Apart from that, it consists of water. So when there is demineralization of inorganic and destruction of the organic substance of the tooth, that would lead to the cavity formation. Now, this one is the definition as per the Sturment. According to the Ostrom or Hume classification, so these all are the various classifications. Now for the entrance exam, you should know where the carious lesion is most commonly observed. Suppose so this one is a tooth, and here is the cavity. So you have to remember that the most observed carious lesion that is found just below the contact areas. Suppose the contact areas are the region where the adjacent tooth will touch. So suppose this one is the contact area. So the caries would be found just below the contact areas and increase frequency at the cemento-enamel junction. Now, these areas are more prone to the plaque accumulation. The tight spaces between the teeth can trap the food particles, so that can lead to plaque retention and provide an ideal environment for bacteria, and that could lead to the cavity formation. So these areas are difficult to clean even with the modern dental tools. So the plaque persists and bacteria produce acid that demineralize the enamel and dentine and ultimately leading to the caries. So bacteria will produce acid that will demineralize the enamel and dentine and then lead to the caries. Other factor is what are the other important is what are the factors that will affect the caries prevalence. First of all, remember that the caries has a lower prevalence in the blacks. So the black individual, they have a fewer caries lesion compared to the white individual. That could be due to the genetic environment or the culture factors. The children that are from lower socio-economic families tends to have a higher prevalence of caries compared to the children with the from that comes from the higher socio-economic backgrounds. Females tends to have a greater total caries experience in the permanent teeth compared to the males of the same age. The girl teeth typically erupt earlier than the boy's teeth. So this earlier eruption exposes their teeth to the oral cavity at a younger age. So female tends to have a higher prevalence of caries due to the earlier tooth eruption and the period of vulnerability before the post-eruptive maturation that enhances the caries resistance. Now, how do we classify caries? We can classify the caries based upon all these classification based on the anatomical side progression. So let us discuss them one by one. So first is based upon the anatomical side. The first caries is the occlusal caries or the pit and fissures caries. So these caries, it is found on the occlusal surface of the posterior teeth, particularly within these pits and these fissures. So leading to formation of the plaque. So since these, due to the anatomy of the pit and fissures, make them less accessible to the natural cleansing action of saliva and the tongue movement. That is why the bacteria will get trapped here. They will produce acid and they will demineralize the enamel, and that would lead to the cavity formation. So prevention and management here is by application of the dental sealants to the occlusal surface that would create a barrier. Fluoride treatment can be one of the choice. So remember, the pit and fissure that have a high steep and a narrow base, they are more susceptible to caries due to the poor self-cleansing features. So what do you will see in the what would be the early appearance of pit and fissure caries? Early stage pit and fissure caries may appear brown or black and feel slightly soft. They may also catch onto a fine explorer point during the dental examination. Now, what would be the extent of these pit and fissure caries? So remember that these caries can spread laterally at dentino-enamel junction, and it can penetrate into the dentine along with the dentinal tubules. So caries progression, remember in Pitt and Fisher caries, it is typically slower as compared to other type of caries. So the treatment is sealants, regular dental examination, and maintaining proper oral hygiene practice. The next type of caries is the smooth surface caries. So smooth surface caries, these caries develop on the smoother surface between the teeth, that is the mesial and the distal surfaces. The proximal surfaces, they are more prone to the caries due to their close contact with the adjacent teeth that can trap the plaque and the food particles. The cervical caries, it occurs near the cervical region of the tooth. So the regular proper use of the dental floss or interdental brush can help to remove the plaque from in between surfaces, that is the proximal caries, in order to prevent the proximal caries. Fluoride treatment can also enhance the resistance of smooth surfaces to the acid attacks. Other is the root caries. The root caries occur on the root of teeth, typically below the gum line. So they appear as black, yellow, so the root caries, it is a soft progressive lesion that is found anywhere on the root surface that has lost the connective tissue attachment and it is exposed to the oral environment. Remember the root caries, you have to just remember that the root caries, it's more common in the older age group. Other is linear enamel caries, that is known as odontoclasia. So linear enamel caries that occurs on the labial surface of the front side of tooth, affecting the upper and lower front teeth. So you would see a linear lines or bands of demineralization on the enamel. You will see white, brown or yellowish line that runs horizontally across the teeth. The cause could be due to the plaque accumulation, poor oral hygiene, diet factors, or xerostomia could be one of the cause. So based upon the severity and rate of progression, we can divide the caries into acute, chronic or arrested caries. What is acute caries? Acute caries progress quickly, so that could lead to extensive tooth damage over a shorter period. So they are often associated with pain or sensitivity due to the rapid progression. The cause could be high sugar diet. So frequent consumption of the sugary food and that would provide a constant supply of the fermentable carbohydrates to bacteria, leading to rapid acid production, and that would cause enamel demineralization. What is chronic caries? Chronic caries, it progresses slowly over taking years to cause significant damage. The lesions tend to be harder, darker and more leathery, indicating slower demineralization. So they are less painful as compared to the acute caries due to their lower progression. Arrested caries. Arrested caries are the caries that have stopped progressing. So they may be inactive and they does not require any further intervention. So rafted caries are typically asymptomatic and they usually do not cause any pain. Other is based on the virginity of lesion, we can classify as initial or primary caries. Initial or primary caries refers to the first occurrence of caries lesion on the tooth that has not been previously been affected by caries. So based on the virginity of the lesion, we can classify caries as initial caries or the secondary caries. So initial caries or the primary caries, it refers to the first occurrence of caries on the tooth surface that has not been previously affected by the caries. Whereas the secondary caries is, it occurs, it develops around the margin of existing dental filling. So it occurs around the margin of existing dental restoration such as fillings, etc. So gap at the margin of the dental restoration, they can allow bacteria and plaque to accumulate and thereby causing a secondary caries. The other is the incipient caries. Incipient caries, it is also known as white spot lesions or initial caries. So remember, they represents the earliest stage of the tooth decay. So how they will appear? They will appear as white or chalky spots on the smooth surface of tooth. On microscopically, you will see that the surface layer is intact, but the subsurface layer, there is demineralization or breakdown of minerals beneath the surface layer. Remember, these incipient caries, it may undergo remineralization, where minerals, they are redeposited into the enamel, reversing the early damage. So that can occur through either through the saliva or through the fluoride exposure. So you have to remember that this white spot lesion may be confused initially with the white development defect of the teeth, and they can be differentiated by their position, shape, symmetry, etc. The residual caries, it is the caries that is not removed during the restorative procedure either by accident, neglect or any intention. And secondary caries, it occurs due to the marginal leakage that we have already discussed. Now caries can be superficial when the enamel layer has been affected and it has not penetrated the dentine, or it can be moderate caries when the caries, it has penetrated up to the dentine, and the severe caries or the deep caries when the caries has penetrated up to dentine layer and reaching close to the pulp. Now, based on the pathway of caries spread, we can classify the caries as forward caries and the backward caries. The forward caries, that is also known as the progressive caries. So here the caries would progress in a forward direction, starting from the outer surface and gradually going deeper into the deeper surface and potentially reaching the pulp. The backward caries, it is also known as regressive or retrograde caries that progress in a backward direction away from the pulp toward the outer surface of the tooth. So these lesions typically occurs in area where there is a decrease in cariogenic factors or increase in remineralization factors. So the backward caries, they are less common and often they occur in specific conditions where the environment within the oral cavity favors remineralization. Now, what are the macroscopic appearance? The earliest macroscopic sign of the incipient caries is the appearance of decalcified area beneath the dental plaque, resembling a white chalky appearance. The enamel surface over the white spot, it remains hard, shiny, and make it indistinguishable from the adjacent sound tooth when you use a sharp explorer. What are the microscopic changes that you would see during the earliest decay? Well, under the transmission electron microscope, the initial changes that occur in early enamel caries, there would be a loss of the interprismatic substance. So you get a question. The earliest change in the early enamel caries is a loss of interprismatic or interrode substance of enamel. There would be increase in the prominence of the enamel rods. So there would be roughening of the ends of the enamel rods that indicate their susceptibility to the early decay. Apart from that, there would be attenuation of increment line of red tears. So the attenuation of the increment line of red tears, they refers to the increased prominence or visibility of lines within the enamel surface. So these increment lines, they are the growth lines or band that are formed during the tooth surface, and they represents the period of growth, interruption or changes in the process of the enamel formation. So they will appear as alternating, these lines, they appear as alternating light and dark band that run perpendicular to the tooth surface. So these lines would be more pronounced. So this increased visibility occur because of the loss of minerals due to the caries process that affect the enamel structure. So making the organic components such as the increment line of red tears stand out more prominently. Apart from that, in a pit fissure caries, you would the carious lesion, they starts along the fissure walls rather than at the base. There would be discoloration. Early dentine involvement may occur if the enamel at the base of pit or fissure is thin. So the caries, remember, in the pit and fissure, they will follow the direction of enamel rods. Another important MCQ point that you have to remember for your exam. So they follow the direction of the enamel rods and they form a triangular or cone shaped lesion with the apex at the outer surface and a base toward the dentino-enamel junction. However, in the smooth surface caries, the base is away from the dentino-enamel junction. The caries lesion in the pit and fissure are more prone to staining with a brown pigment that may undergo underlying tooth decay in the newly erupted teeth or arrested lesion in an older individual. So when the caries in dentine, the first component that is involved is protoplasmic extension within the dentinal tubules, that you have to remember that decay it starts in enamel and gradually it involves the dentine. Now based on classification, that is based on number of the tooth surface involved, we can classify simple, compound or complex type. The simple is when only one tooth surface is involved, compound when two surfaces are involved, complex when it involves more than two surfaces of the tooth. There was a question in your entrance exam, the compound type was asked and it involves the two surface of the tooth. That was the answer. Now based upon the chronology, we can classify caries as early childhood caries, adolescent caries or the adult caries. Based upon the surfaces to be restored, we can use the code O for occlusion surface when that is involved, M for mesial surface, T distal, F facial, P buccal and L lingual surface. And if the combination are also possible, like when the mesial, occlusal and the distal surfaces are involved, then we can use term mesio-occlusio-distal surface. Now next comes the Black's classification. So based on that, we can classify as the first is class 1 lesion. So that involves the pit fissure and the defective grooves. So pit fissure and when the caries involves the pit fissure and the defective grooves. Occlusal surfaces of the molar and premolar, occlusal 2/3 of buccal and lingual surfaces of molar and premolar, of the molars and the premolars, and when it involves the lingual surfaces of the anterior teeth, that is class 1 lesion. The class 2 is when it involves the proximal surfaces of the bicuspid. So when the proximal surfaces are involved, of the bicuspid or molars, that is class 2 lesion. Class 3 is on the proximal surfaces of the anterior teeth that does not involve the removal of the incisal angle. So, and class 4 is when the incisal angle is involved, that is caries or lesion found on the proximal surface of anterior teeth that involves the incisal angle. Class 5 is lesion on the gingival third of the facial and lingual surfaces of the anterior and the posterior teeth. So gingival third of the molars and the anterior teeth is the class 5, and class 6 is lesion involving the cusp tip and the incisal edge. The WHO classification, We can classify the shape and depth of caries lesion scored on 4-point scale: D1, D2, D3 and D4. D1 is clinical detectable enamel lesions with intact surface. D2 is when the cavities are limited to enamel. D3 when the cavities are detected in dentine, and D4 lesion is when the lesion it extends into the pulp. Other classification is classification by mount and human. 3 site of carious lesions: site 1, site 2 and site 3. Site 1 is pit and fissure and enamel defect that are found on the occlusal surfaces of the posterior teeth. Site 2 is when the proximal enamel is involved below to the areas in contact with the adjacent teeth, and the cervical 1/3, and site 3 is the cervical 1/3. So first is pit and fissure, second is area below the contact areas, and third is the cervical region, that is the site. Other is the size 1, size 2, size 3 and size 4. Size 1 is minimal involvement of the dentine. That means the dentine has not penetrated deep into the tooth and can potentially be treated through remineralization. So if the pit and fissure surface is involved, it's 1.1, 2.1 for the contact area, and cervical third is 3.1. So there was an MCQ in your exam asking 2.1 means, so that would be the size is minimal and it is affecting the site, that is contact area. The lesion is found proximally and it is minimal. Moderate involves involvement of the dentine. Here the decay will be progressed a little further, but the remaining enamel is intact and it is supported by the dentine. The third is the size 3 and last is the size 4. So remember that for your entrance exam point of view. Next, moving to the radiation caries. Radiation caries that occurs, also known as radiation induced dental caries, that occur as a result of the radiation therapy. So it is associated with, remember, xerostomia. So dry mouth due to the decreased salivary secretion. So this decrease in the saliva flow result in increased saliva viscosity and lower pH. That would create an environment to the caries. Remember, xerostomia and other factors that are associated with the radiation therapy, they can contribute to development of the rampant caries. That is a severe and rapidly progressing form of the dental decay. Now, what are the types of defect due to the radiation? The first is the lesion that encircle the neck of teeth. So these lesions may be extensive. Apart from that, there could be brown or blackish discoloration of the teeth. Apart from that, you would see spot depression. So radiation induced caries can also present as spot depression on the tooth surface. So these depression may start small but can spread rapidly, affecting the integrity of the tooth structure. Now let us discuss the points that are involved in the etiology of the dental caries. The first of all, it's the dental plaque. So dental caries begins with the accumulation of dental plaque on the tooth surface. We know plaque, it is a biofilm that is composed of bacteria food particles, and the saliva components. So remember the S mutans and lactobacillus species. They are the primary culprits in development of the dental caries. So these bacteria, what they do is they metabolize the sugar from food and producing acid as a byproduct. So that lowers the pH in the oral environment, leading to demineralization of the tooth structure, and this demineralization would weaken the enamel and hence make it susceptible to decay. Second is the sugar and the carbohydrate consumption. Diets that are high in sugar and fermentable carbohydrates, they provide ample fuel for cariogenic bacteria. So sugars from the food, especially sucrose, glucose, so they serve as substrate for bacterial fermentation that leads to production of the acids. The saliva, it plays an important role in maintaining the oral health by buffering the acid, remineralizing the enamel, and washing away the food debris and bacteria. So the condition that reduces the saliva flow, that are termed as conditions like xerostomia, certain medications can increase the risk of dental caries by impairing the saliva protection function. So remember, as the cariogenic bacteria, they ferment sugar, they produced organic acid, primarily the lactic acid, that is the byproduct of their metabolism. So these organic acid would lower the pH in the dental plaque and surrounding environment. So this is the primary mechanism of the caries formation. I have already discussed that. Now let us move to the theories of the dental caries. The first is the early theory of the dental caries, that is legend of worm theory. The legend of tooth worm is the one of the earliest explanation for the tooth decay. So previously they believed that there is a worm-like creature that is cause of the dental problem. So this worm was thought to burrow into the teeth and consume the blood, leading to pain and decay. So fumigation devices were used in the form of dental treatment. These devices were attempted to drive out of the supposed tooth worm through the use of aromatic or medicinal substances. Other theory are the humoral theory. According to the humoral theory, the health and disease, they are determined by a balance of four bodily fluids. Four humors of body, they are blood, phlegm, black bile, and the yellow bile. So any imbalance or alteration in the relative proportion of the four humors, that could lead to disease. Example is excess of black bile was thought to cause depression, excess of yellow bile was associated with anger. So this was about the humoral theory. The vital theory. So the vital theory recognized the teeth as a living tissue with their own blood supply and nerve innervation. So according to the vital theory, the tooth decay originated from within the tooth itself. That is like how gangrene develops in the bone. So it was believed that the decayed process were initiated internally, possibly due to factors like changes in the dental pulp or disruption of the tooth internal environment. Other theories are the chemical theory, parasitic theory, Miller chemico-parasitic theory, proteolytic and proteolytic chelation theory. The first is the chemical theory. So remember the chemical theory, it was given by Robertson. That is, you have to remember for your entrance exam point of view. According to the Robertson, he emphasized the role of the fermentation of food particles around the tooth. It was proposed that the fermentable carbohydrates in the diet, they undergo fermentation by the oral bacteria, and that lead to the production of acidic byproducts. So the acid formed as a result of fermentation and putrefaction were thought to erode the tooth enamel. Other theory is a parasitic theory. The parasitic theory was proposed by, remember, Leeuwenhoek. The microorganisms, they play an important role in development of the dental caries. Leeuwenhoek made microscopic observation of the scraping from the teeth and carious lesion. His observation revealed the presence of microorganisms including bacteria that are associated with the dental decay. Other is the Miller chemico-parasitic theory. According to Miller, there are two stages of dental decay. First is a decalcification of enamel. Here, the acid produced by bacterial fermentation of starches and sugar in the oral cavity lead to decalcification of enamel that results in total destruction of enamel. Second is the decalcification of the dentine. In second stage, the acid continues to demineralize the dentine, causing its decalcification. So according to the Miller theory, the acid responsible for demineralizing the tooth structure, they are derived from fermentation of starches and sugars that are present in the oral cavity. So Miller chemico-parasitic theory laid the groundwork for our current understanding of the etiology of the dental caries. So most accepted theory is Miller chemico. Other is proteolytic theory. Proteolytic theory was given by, remember, Gottlieb. According to the proteolytic theory, the initial process in the dental decay involves the proteolysis. What is proteolysis? That means the breakdown of the organic component of the tooth structure. That includes proteins that are found in enamel, dentine and other organic matrices of the tooth. So the proteolysis of this protein that results in degradation and weakness of the organic matrix of the tooth. Other theory is proteolytic chelation theory. It was given by, remember, Schwartz. According to this theory, the dental decay involves the simultaneous action of the oral bacteria in degrading organic component and dissolution of the minerals in the tooth structure through chelation. So chelation means formation of soluble complexes that is known as chelates. So chelates involves the removal of the calcium ions from the tooth mineral matrix by forming soluble chelates. Other theories are the sulfatase theory. It was given by Pincus. The sulfatase theory said that bacteria in the oral cavity possess sulfatase enzyme. So these enzyme has capacity to hydrolyze or break down the sulfate containing compound that is present in the organic matrix. So bacterial sulfatase, they are believed to target mucotin sulfate in enamel and chondroitin sulfate in the dentin. So that are the integral component of the organic matrix of the dental tissue. So on hydrolysis, there is production of sulfuric acid that in turn causes decalcification of the dental tissue. Other is the complexing and phosphorylating theory that was given by Leura. Now the current concept is the Caries triad and Caries tetralogy. So what is who gave the Caries triad? It was given by Dr. Paul Caries in year 1960. According to it, the three factors triad: susceptible host, cariogenic plaque, bacteria, and high sugar diet, they are responsible for dental caries. And in the Caries tetralogy, it was given by Newburn. So the Newburn emphasized the role of time in the development and progression of the dental caries. Prolonged exposure of tooth to fermentable carbohydrate and acidic condition, they increase the risk of demineralization and decay. So new factor time was also added here. Now let us discuss the role of microorganisms in the dental caries. We know that dental caries, it cannot occur without the presence of microorganisms. So what are those microorganisms? Important microorganisms are S. mutans, S. sanguis, S. milleri, S. mitier, S. oralis. So these are the important microorganisms. Lactobacilli acidophilus, remember S. mutans, it is very common in the Pitt and Fisher caries, whereas the lactobacilli, they occur in deep dental caries. Important for your exam point of view. Now S. mutans, we know it's actively involved in initiation of dental caries. S. mutans, it is commonly found in plaque, incipient lesions involving Pitt, Fisher, or the smooth lesions, smooth surface caries. For the root surface caries, the most common microorganism is A. viscus, actinomycosis viscus, that you have to remember that. Vanilla strains increases in number in dental plaque after lactic acid producing organisms they have colonized. So the main most extensive bacteria involved in oral cavity, they are the streptococci. S. mutans, S. sanguis, S. miter, S. salivarius. So these are the, we know S. mutans, let us talk about that. S. mutans, they are facultative anaerobic bacteria, right? More characteristic feature, let us talk about them. They are facultative anaerobic, catalase negative, gram positive cocci, and form short chains. On mitis, salivarius agar medium, remember they form colonies that are convex in shape. So remember all these things for your entrance examination. The important characteristic of cariogenic strain of S. mutan is their ability to synthesize insoluble polysaccharide. Remember S. mutans, it is a homofermentative, that means it produces lactic acid as byproduct, and it is more acidic. That means it is more acid resistant compared to other organisms. Also, as mutants, it is not found freely in the nature, but it has been isolated from the oral cavity of the humans and certain animals. The colonization of these S mutants in the oral cavity, it begins after the eruption of teeth in the infant. Now, entrance exam question is, S mutants, they have been divided into various serotypes, that is from 8 serotypes. Remember that, designed from A to H, that is they are characterized by specific antigen that are present on their cell wall. Now the S mutants, they primarily metabolize the disaccharide sucrose, that utilize it for energy production and generating the acid that we discussed is the lactic acid. So glucose and fructose from the sucrose, they are polymerized by S mutants to synthesize extracellular glucons and fructose. So these glucons, particularly the mutants, they will serve as adhesive component in plaque formation that contributes to S mutants attachment to the enamel. Now, what is the role of extracellular polysaccharides? Extracellular polysaccharides like glucons, fructones, they are structural component in plaque formation. So these glucons contribute to plaque adhesiveness. So the intracellular glycogen and extracellular polysaccharides, they will serve as a reservoir for the S mutants that will provide and support energy production when the exogenous carbohydrate source will get limited. Other important organism is, remember, S. sanguis. Remember that it is found in both karyogenic and non-karyogenic plaque. S. salivarius, that is found in the tongue, throat and saliva. So these all are the important microorganisms. Now, what are the primary factors? Let us discuss about the primary and the secondary factors. The primary factors: flora, susceptible host, karyogenic diet. The secondary factors are time, pH and the saliva that are related with the caries. The dental plaque, we know it's a microbial structure that accumulates on teeth. It appears as tenacious thin film that resists removal by physiological and oral cleansing forces, but it can be removed by the toothbrushing. The dental plaque, we know it consists of mucin, desquamated epithelial cells, microorganism, salivary proteins, carbohydrates, lipid, etc. Remember, bacteria and salivary proteins, they accumulate for the about half the dry weight of plaque, while carbohydrate, they contribute around 25%. Remember that. The major strain of streptococci that are present in plaque are the Asmutans, sanguis, Mitter, Milleri, salivarius. Actinomyces species include Actinomycosis viscus, Neslandi, Israeli. So these are the various microorganisms. Now bacteria, we know it initially attached selectively to acquired pellicle, that is a proteinaceous layer that is formed on tooth. So this pellicle has a semi-permeable properties to the enamel surface. What is role of this salivary pellicle? The bacteria attached to salivary proteins, they are absorbed to the enamel surface. Both bacteria and natural surface including teeth, they present a negative charge. In first stage, the bacteria, they are attached to surface by van der Waals forces. The contact is hindered by repulsive forces of negative electrostatic forces. The second phase involves firmer binding, forming bonds that could be hydrogen bond, ionic bond, etc. Apart from that electrostatic interaction, they play an important role in adsorption of bacteria like the Asmutans to pellicle. The teichoic acid contributes to net negative charge of the bacteria and may interact with the positive charge site on the pellicle that would facilitate the attachment. So this is how the pellicle attaches with the bacteria, they attaches. So these are the primary modifying factors, secondary modifying factors. Remember that for your exam point of view. The fifth Gerland post stated that microorganisms are pre-required for the Caries initiation. Remember, not all kind of acid producing organisms are cariogenic. So these are the property of the Asmutans. Coming to the window of the infectivity. The window of infectivity, it refers to critical period during the eruption of primary teeth in infants and the young children, where the colonization of Asmutans occur. Remember the term window of infectivity, it was given by Cauffield in the year 1993. So based on his observation of streptococcus level in children from the birth up to the age of the 5 years. Now during the eruption of primary teeth that occurs between the 6 and 30 months of the age, the oral cavity provides a sterile environment. As the primary teeth emerge, they provide a wedging habitat that enables the streptococcus to colonize the oral cavity. So without facing any competition from the established other bacteria. We know that mutants is particularly significant in dental caries. Why? Because it has ability to metabolize sugar and produce acid that contributes to demineralization of enamel. So once established in oral cavity, these streptococcus mutants can form biofilms. According to the Cauffield, his research observed that the streptococcus, it can colonize during the eruption of the primary teeth. with most children acquiring these bacteria up to age of 7 to 31 month of age. So this period of initial colonization represent the this period represents the window of the infectivity. So as it marks the crucial time when the oral microbiota is being established. Remember, Cross in 1967 contributed he gave a second window of infectivity period. They likely found that the children between 2 to 6 year of age were less susceptible to acquiring streptococcus. The second window of infectivity is present in the permanent dentition between the age 6 to 12 years of age as new teeth erupt. So as the new permanent teeth erupt, they provide a new surface for bacterial colonization that lead to increased susceptible to these streptums during this period. So the first window of infectivity period is between, remember the time period is between, remember the time is 6 to 30 month of age, and second window of infectivity period is between 6 to 12 year of age. Now three aspects of tooth that have to be considered. First is composition, second morphological character, and third is the position. So remember that the surface enamel, it's more resistance to caries than the subsurface enamel. The subsurface enamel exhibit marked decalcification in initial caries lesion, while the surface remain intact. Fluoride content, the sound teeth it contains higher fluoride content, that is 0.01 percentage as compared to the carious tooth. Accumulation of fluoride, we know it will contribute to resistance of enamel to the caries. Surface enamel accumulates more fluoride, zinc, lead and iron. It contains less carbonate, less water and more inorganic material as compared to the subsurface enamel. The surface enamel exhibit improved crystallinity of apatite crystal that make it more stable. Remember that fluoride content in sound enamel is 410 ppm, and for dentine it's around double, that is 873 ppm, whereas fluoride content of the carious tooth is for the enamel is 139 ppm and for dentine it's 223 ppm. Now let us consider about the tooth morphology. Well, the deep, narrow occlusal fissures or pits can trap food, bacteria and debris, predisposing to the caries development. Certain tooth structures are more prone to decay, with mandibular first molar being the most susceptible. The third and the last is the position. What is the importance of the tooth position? Malaligned, rotated or improperly positioned teeth make cleansing difficult. So these teeth tends to accumulate more food and debris creating an environment that can lead to caries. Saliva factor. The saliva, we know, it acts as a buffering agent that can affect the dental health. Bicarbonates, carbonic acid and phosphate, they are the chief buffer system that are present in the saliva. So higher the salivary rates increases the bicarbonates and enhancing the bicarbonates buffering capacity. The active carious lesion exhibit a pH gradient that being more acidic than the shallower layers. The saliva, we know, it will help to neutralize the acidity in the carious lesion. That is why it will contribute to the pH stabilization and slowing down the lesion progression. Apart from that, saliva, we know, it contains antibacterial components. What are those? They are lysozyme and salivary peroxidase system that would help to inhibit the bacterial growth. The saliva viscosity, it largely is due to the mucin content. The most predominant immunoglobulin that is found in saliva is secretory IgA. Remember that for your entrance exam. So under the normal resting condition, the pH of dental plaque, it remains constant. But following the consumption of sugar or exposure to the sugary substrate, the pH of dental plaque rapidly drops. So this drop in pH occurs due to fermentation of sugar, leading to production of the acid. So after the initial drop, the pH begins to return to its original value. So dental caries is outcome of imbalance between demineralization and remineralization cycle that continues throughout the life. The next important part is the Stephen's curve. Well, Robert Stephen, he discovered a continuous change in the salivary pH. The Stephen curves, it helps to visualize the dynamic nature of the demineralization and the remineralization cycle in a dental plaque following after the glucose release. So Stephen curve, it's a graph that reflects the fall in pH before, during and after the glucose release. The first is the resting pH. Under normal condition, the pH of dental plaque remains within the range of 6 to 7. So this pH range indicates a neutral or slightly acidic environment where no sugary substances are consumed. So following the consumption of sugar, there is a rapid decrease in pH of the dental plaque. The third landmark on the Stephen curve is the critical pH, and its value is, remember, 5.5. Now what is critical pH? It is the threshold at which saliva is no longer saturated with calcium and phosphate ions. So when the pH drops below this critical pH, it leads to state where the hydroxyapatite in the enamel, they are susceptible to dissolution. So this dissolution of hydroxyapatite that indicates a net loss of the minerals from the enamel structure. The process we call it as a demineralization. So demineralization, it is important to note that the critical pH, it is estimated to be around 5.5. So as the pH it decreases below this critical pH, the solubility of hydroxyapatite increases. So remember, for each unit decrease in pH below the critical level, the solubility of the hydroxyapatite increases tenfold. The fourth landmark in the Stephen curves represent the increase in the pH following the acidic change. So after there is decrease in plaque pH due to the acidic challenge from the ingested sugar, there is gradual restoration of the pH back to the normal range, that is 6.3 to 7. So this increase in pH occurs over a period of time, generally about 30 to 60 minutes. Now various factors influence the rate of pH recovery. That could be buffering capacity of saliva, metabolism speed of the carbohydrate, density of the plaque. So these factors would affect the remineralization to occur. So this is about the Stephen's curve, a very important graph that is important for your entrance exam point of view. Now let us discuss about the various studies. The first is the Hopwood House study. So this study it lasts for the 15 years, that is from 1948 to 1963. Location, it was conducted at Children's Home in New South Wales, Australia. That is also known as Hopwood House study. So what was its objective? The study aimed to investigate the impact of diet on the dental caries activities in the children. Diet, the children at the Hopwood House had a significant different diet compared to average Australian family household. So their diet mainly consists of refined carbohydrates and minimal animal protein. The majority of food were eaten uncooked. Main source of carbohydrate were whole meal, bread, soya beans, etc. So the result was the children at the Hopwood House had a much lower incidence of dental caries compared to the general population. Other was Whipham study. So it was conducted from 1945 to 53 at the Whipham Hospital in the Sweden, an institute for mentally deficient children. So the aim was to determine how different factors related to the sugar consumption, such as the type of sugar ingested and frequency of sugar intake, affect the development of the dental caries. So on finding, it was noted that there was positive correlation between the sugar consumption, both between the meals and at the meals, and the incidence of the dental caries. The sticky food were found to have a high correlation with increased Caries activity compared to the non-sticky food. Other was Turku study. Turku study conducted by Shedin and McKinnon in Turku aim to compare the effect of sucrose, fructose and xylitol. So there were three groups of participants, each consuming different sugars. Group 1 were sucrose, group 2 fructose and group 3 xylitol. And after 1 year it was found sucrose and fructose were found to have equal karyogenicity. After the second year the fructose group showed no new Caries development, whereas there was increase in the sucrose group. So the sucrose was concluded to be more karyogenic compared to the fructose. So these are the various studies that were conducted. Now let us discuss about the histopathology of the caries. First of all, the histopathology of the enamel caries. So this is a figure of early lesion of the smooth surface caries showing a chalky white spot on the tooth adjacent to the contact point. So there would be loss of interrode substance, attenuation of stria of red gears, as we have discussed earlier. Now there are 4 zones from deepest. They are the first zone is the translucent zone. The first recognizable alteration from normal enamel in progression of enamel lesion. So it is unrecognizable clinically and radiologically. So this zone is slightly more porous than the sound enamel, having a pore volume of 1%. So when viewed in transmitted light after treatment with quinolone, the zone appears structureless. The zone 2 is, so this one is the translucent zone. The zone 2 is the dark zone. Third is the body of lesion, and fourth is the surface zone. The dark zone, remember the dark zone is adjacent and superficial to the translucent zone. It is commonly present and it is formed as result of the demineralization. So the pore volume is 2 to 4%. The zone 3 is body of lesion. The body of lesion, it is situated between the unaffected surface layer and the dark zone. So it represents the area of greatest demineralization. Remember, the area of greatest demineralization is the body of lesion. And it has a pore volume of 5% near periphery and 25% in the center. The next zone is the surface zone. It is the outermost layer of the lesion. There is So this zone is more heavy mineralized, having a pore volume of only 1%. The surface zone remains intact and well mineralized due to the remineralization. The calcium and phosphate ions relieved by the subsurface dissolution become reprecipitated here. So the high fluoride concentration on the enamel surface, it favors remineralization. This zone is demineralized by time caries penetrates the dentine. So what would you see in ultrastructure analysis? The first alteration in the enamel caries is the destruction of the apatite crystals. They will be destroyed, both within the enamel prism as well as their boundaries. So progressive dissolution of crystal that would lead to broadening of intercrystalline spaces. So this broadening is more detectable in the body of enamel carious lesion, with having a higher pore volume of around 10 to 25%. As the number of dissolved crystal increases, the densely calcified tissue, it becomes more porous. So with the diffuse destruction of the apatite crystal, numerous bacteria can be observed invading the enamel lesion. So these are the ultrastructural changes that occurs in enamel caries from initial crystal destruction to the bacterial invasion. So what are the early changes during the dentinal change? What are the early dentinal changes in the caries? So once bacteria penetrate the enamel, they will spread laterally along the dentino-enamel junction and attack the dentine over a wide area. So the changes that would you see is the fatty degeneration. The bacteria will liberate proteolytic enzyme and bring about destruction of the organic matrix that is already softened by the demineralization. So first change that would you see in the caries process within dentist is the fatty degeneration of the Tomes fibers with the deposition of the fat globules. Two types of lipid observed, one possibly of the bacterial origin and other unmasked by the demineralization. So that is followed by dentinal sclerosis, that is minimal in rapidly advancing acute caries and maximum in slow chronic caries. 5 to 6 years the S mutants show enamel penetration of about 2.7 mm. So all these microorganisms produced extracellular polysaccharides, and the number of lactobacillus they increase only after the carious lesion has developed. Remember that